Okay, thank you very much. And good morning, everyone. And sorry for the technical glitch. Uh, in fact, I'll be discussing the uh, technology. I mean, that is the atrial fibrillation ablation, a different technique that already we had heard about PFA. And in India, PFA has not reached so far, and cryo reached 3 years back. In our experience with the cryoablation in the last 100 cases, we know cryoablation has certain advantages over radiofrequency ablation because it has reduced the risk of thrombus formation and a better demarcated lesions, lesser LA dwelling time because it is a single shot technique, and probably more precise lesions and less collateral injury. So it has already been known that based upon the fire and ice study that it is non-inferior, and also the learning curve it's quite steep. It's very can be learned very easily, and many centers have already started doing with a lesser experience and lesser operator dependence of this technique as compared to radio frequency. This is the center in southern part of India that is very close to the southern peninsula of India. That's from Kerala, so, SCT which is a public health sector hospital under the government of India, an institute of national importance, where we do around 1,000 procedures a year, and out of which this is on atrial fibrillation ablation with the cryo only. We just select the cases based upon the existing guidelines. Most of these patients are already on class 3 agents or flecainide, amiodarone or flecainide, and they have then only if they have recurrence, then only we take up these cases for ablation. We discussed options and the expected outcomes in detail. A detailed echocardiography is done to assess the LAVI, LA strain, etc. A dedicated 256 slice cardiac CT is done in all these cases for detailed information on pulmonary veins and LA anatomy. A TES routinely done in any other center, and a deep sedation with a laryngeal mask airway ventilation with no diaphragmatic paralytic agents. These guidelines are very well known. And the cryoballoon, that's a 4th generation, steerable sheath, spiral mapping catheter in all, 3D electroanatomical mapping. EnSite is used in all these cases with the image integration NavX fusion, esophageal temperature monitoring, diaphragmatic function monitoring, eyes guidance, ACT monitoring to keep it between 300 to 350, arterial pressure monitoring, and low flow pressure irrigation of sheath. This is the CT scan, and it's done in all these cases to give a complete clear anatomy, and then we assess with a detailed echocardiography as well. Then with the anatomical parameters are also recorded and looks for specifically the LAVI, eccentricity index, ovality index in all these cases. Additional pulmonary veins are noted. And the venous axis, we take a right internojugular, right femoral, left femoral 2, one for the eyes and the his bundle, radial line, esophageal temperature monitoring, continuous low pressure irrigation of the sheaths, and heparin we give in the initial phase 1,000 units, then 7,500 after the septal puncture, then addition of 5,000 units before the first balloon inflation. ACT every 20 minutes to be the fourth, so that it is kept around 300 to 350. Inferior part of the septum, a low puncture is preferred. And as you know, it gives better approach to the right inferior pulmonary veins. If the puncture is slightly higher, the coaxiality of into the right inferior pulmonary vein is a problem. And when you puncture in the proper place, we can get easily into the right inferior pulmonary vein. So puncture is also guided by the eyes in most of these cases, though we are very familiar with puncture without eyes. We're having, doing a lot of left lateral pathways and all. Almost 200 procedures every year are being done without eyes for the septal puncture. So still for these cases, we prefer to have eyes in almost half the number of cases, and it's guided by the eyes especially in complex cases. So this is the image fusion integration, and all pulmonary veins and the left atrium are mapped in the very beginning. And this is venous occlusion is often confirmed with the contrast medium injected through the central lumen of the balloon. pressure tracings, and if ice is done in that particular case, ice flow as well. So this is the leakage from carina into the inferior part, no leakage afterwards. Then the common pulmonary veins, then the LSPV, electrical isolation, it's confirmed clearly. And if the isolation happens within a 90 seconds or so, on the left side we give for 240, and on the right side 180 seconds. Persistent PVI verified by Achieve catheter recording 10 minutes after the last freeze application is considered as the procedure as endpoint, successful endpoint. Demonstrate the entrance and exit. You can see the esophageal temperature is monitored, and once it reaches 27 degree, a double tap is done often, and it's so that it doesn't go much below. Then the right inferior pulmonary vein occlusion, and you can see that isolation, then the isolation point. As you can see in this case, some of the pulmonary veins we see firing in the beginning and atrial fibrillation. Once the isolation happens, then you can see the atria is in sinusoidum, while when pulmonary veins fire continuously, and with the continuation of the ablation, the pulmonary veins also stop firing. And this is, noted in a handful of cases. And often this shows the exit block in the beginning and complete isolation with the AFib not inducible. Sometimes we need a hybrid approach when the ablation, cryo has not given a complete isolation. As you can see in this case, a touch-up with the RF would help to achieve good isolation. There's a positioning and checking of the diaphragmatic pacing with the CRD catheter, a curved one, which gives very good stability. And it's also monitored with the CMAP and also hepatic vein Doppler. And CMAP, we keep a threshold to by around 30% lesser. Once the moment it reaches there, it touches, then we stop it. And also look at whether in the AP view, whether it is lateral to cardiac cell height, then we are more cautious. And this is how the isolation, RIPV isolation. With these techniques, it has not been very difficult to get into the right inferior pulmonary vein, and all the pulmonary veins are isolated sequentially, and afterwards a voltage map is created and look for and confirmed again with multiple mapping and exit block and entrance block demonstration, figure of 8. In the ICU, these patients TT after 6 hours, then the ECG, proton pump inhibitors, NOACs are reinitiated. We give amiodarone or fluconate for 3 months, and after a blank period of 3 months, outpatient clinic visit at 1, 3, 6, and 12 months with the 12 lead ECGs, regular telephonic interview. If the patient had any symptoms, we go for the extended loop recorder as well. So over a period of last 3 years, 103 cases, then mean age of 55 years, 6 redo cases, LA 35 plus or minus 6, 27 cases had LA more than 40 millimeter, 5 had more than 50, largest was 63. All cases we use 3D electronatomical mapping. ISO was used in 60% of cases. Hybrid approach, thereby meaning that RF for touching up the lesion had to be used in 8 out of 103, mean follow-up of 30 months, maximum follow-up 42 months. As you can see, all the pulmonary veins were nearly isolated except one. LA fluoroscopy time was quite low, 27, and LA dwell time was only 55 minutes. The initial 10 cases, 2 of them had transient phrenic that was under guidance by external proctors, and then we had started using all these multiple safety mechanisms, and none had afterwards. On one mortality which is not related to the procedure, died 1 year after the procedure due to dengue fever. One patient had TIA, but this patient's stat score was 1. Then for late recurrence after 3 months, only in 14 cases. So with this hybrid approach, that is, whenever there is a reconnection or a non-isolation, we had to touch up these cases. That is 8 out of 103. We had 86.4% remains in sinusoidum at a follow-up of 30 months. So combination of all these factors helped us to achieve good success rate compared to existing literature. It's a safe and effective procedure. No major complications, a short delayed dwell time, and good efficacy outcomes. Probably this hybrid approach, 3D electroanatomical guidance, and a strict protocol probably help to improve the acute procedural and long-term outcome. Thank you.